What should we do? Okay, let me see how many slides are there. How many more slides are there? There says it's a few more slides, so let's get on with it, huh? Oops. Oops, 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 oops. Sorry. Okay. Okay, so incretins. I've been saying incretins. So what is incretins? Incretins is this monster's saliva. So they were first. This monster is called Gila monster. It is found in Africa and in North America. And what does it do is that it has a venom. So it was seen whenever this animal bites someone, that person used to go into hypoglycemia. So from here we found, then the saliva was looked into and the incretins were found. So what happens? The incretin is GLP-1. GLP-1 is the is released from the intestines. Okay, when we take food, this GLP-1 is released when the food enters in our body from our stomach. GLP-1 is released. This GLP-1 acts on the pancreas. It causes glucose dependent insulin secretion. So this glucose dependent means that if there is high glucose levels, the pancreas will release more insulin. If there is low glucose level, the pancreas will release low insulin. It also helps in the synthesis of insulin. It is also responsible for formation of the beta cells. And then it also causes glucose dependent decreased production of glucagon. This GLP-1 also has effect on liver and decreases the glucose production. It acts on the brain, and brain has and causes satiety. So man thinks that he doesn't need to eat more. It not only that it affects the brain, it also affects the stomach, and in the stomach it decreases the gastric emptying. So when there is decreased gastric emptying, the stomach is full and stomach feels, because the stomach is full, so you feel full, you feel patient feels satiety, and that's why he doesn't take more meal. And it also has been found to have cardioprotective function. So this is the incretin effect, the GLP-1, the new drugs, the rocket science of the new drugs of diabetes. DPP-4 inhibitors. So what is DPP-4 inhibitors? So what happens is that when this GLP-1, when this GLP-1 is released, and it causes that so much effects, so many good effects. But then there is an enzyme known as DPP-4 enzyme, which acts on this GLP-1 and takes it and converts it into inactive form. That's why, because of this enzyme, this GLP-1 has a very short life. It has a very short life. And so the scientists, they came up with DPP-4 inhibitors. So DPP-4 inhibitors, what they do is they inhibit this conversion, they inhibit the enzyme, thus prolonging the life of this GLP-1, and thus the good effects produced by the GLP-1 in the body. So this is the normal incretin effect. When you take the food, the oral glucose is given to the patient, and you can see the black dot shows the oral the insulin response after giving the oral glucose. So your normal insulin, when you give oral glucose, in response to this oral glucose, there is high insulin release. Okay, to the oral glucose. Incretin effect will happen if patient has been given oral glucose. So you can see how much high insulin, this is the amount, this is how much high insulin is released in these patients, in the normal people, when the insulin when the glucose is given. But what happens in diabetes? In diabetes patients, this incretin effect is diminished. The release of the insulin from the pancreas is reduced. Insulin release is reduced. You can see the height of the height of this graph. You can see it has flattened. You can see the curve has flattened. The curve has flattened in the type 2 diabetic patients. There is impairment of the release of insulin to the oral glucose. So inappropriately low insulin is released. This is the diminished incretin effect is there. So where several studies were done, the TACOS study is the done which was done on sitagliptins. This is a group of this. This is one of the drugs of this group, and it has shown that it was non-inferior and had very good outcomes in patients with cardiovascular disease. So there was no signal for increased heart failure or hospitalization in patients who were taking sitagliptin, which is a member of this which is one of the DPP4s. So cardiovascular outcomes, very important. With now, cardiovascular outcomes has become the targets for the newer drugs, and I will tell you why when we go to another group of drugs, another new group of drugs. So these are the newer drugs which are being which are in DPP4: the saxagliptin, alogliptin, sitagliptin, linagliptin. So of these, sitagliptin is the one which is readily available in Pakistan, and it has shown very good effects on the cardiovascular outcomes. Number two, the drug which the second new drug group is SGLT2 inhibitors. And these SGLT2, what are the SGLT2? These are the channels which are present in the nephrons and are responsible for reabsorption of the glucose. So we have SGLT2 and SGLT1 channels. There are two types of the channels. And SGLT2 inhibitors, which they do is when you use this glucose, instead of being absorbed, is excreted in the urine. So SGLT2 inhibitors reduces glucose reabsorption in the proximal tubules. Okay? So when you give SGLT2 inhibitors, there is reduced absorption of the glucose in the proximal tubules, and there is increased urinary glucose excretion and osmotic diuresis. So what happens? You lose your glucose in the urine. So there is excessive glucosuria. Insulin independent action. This is insulin independent. They cannot see whether the glucose levels are high or low in the body. So the incretins has a better effect. It has advantage that they are glucose dependent. So if there is raised levels of the glucose, they will produce their effect. So chances of having hypoglycemia there is low. But SGLT2s are the ones which have which are insulin independent. So they do not require insulin and they do not depend on the glucose levels. So they improve the glycemia and reduces A1C ranging from 0.6% to nearly 1%, mild reduction in blood pressure, low risk of hypoglycemia, and modest weight loss because of the loss of the water. And dapagliflozin is the one which has shown a better cardiovascular outcome. There are studies on this, and they decrease the albuminuria, they decrease the uric acid, they increase the LDL and HDL, they decrease the glucose. So there's a lot of studies going on which have shown that the SGLT2 are one of the better drugs which are coming up, and we are now being prescribing these drugs as well. Dapagliflozin or empagliflozin are two drugs which are being used, and empagliflozin is the one which has shown best cardiovascular outcomes and is the one which has resulted that now all the drugs which are being used for diabetes have to show good cardiovascular outcome. So empagliflozin and dapagliflozin are the drugs. The more I think, the more confused I get. So diabetic therapy and diabetes is getting confusing day by day. So we come to non-insulin injectables. Till now, the only injectables used for the treatment of diabetes were insulin. But now we have come up with the non-insulin injectables. And what are they? They are GLP-1s. Yes, these are incretins. Let me go back to the incretins. Sorry, just quickly do this is new stuff and I really like it. So this GLP-1 itself, so we were doing DPP-4s which inhibit the breakdown of the GLP-1s, but these non-insulin injectables are actually this GLP-1 itself. So the very first GLP-1 was exenatide. It is a very short acting. It has 5 to 10 minutes duration effect, and then its effects are finished. And its action duration of action is just 5 to 10 minutes, and therefore it has to be given in continuous infusion. So it was, and then we found out that exenatide caused pancreatitis. So it has been removed from the market, and then there were changes done to the molecule of the exenatide, and we came up with a drug named liraglutide. Liraglutide causes insulin secretion in a glucose-dependent fashion, causes beta cell sensitivity, increased insulin synthesis, glucagon secretion is reduced, hepatic glucose output is reduced, increases the satiety, decreases the weight, increases energy intake. It is being available by the name of Victoza, and its body weight effect on body weight is so good that in higher doses is known as Saxenda, and it is being used for weight loss, the liraglutide in higher dose. And the leader study has shown that it also has very good cardiovascular outcomes. Okay, so it reduces the risk of 3-point MACE endpoints, that is the myocardial infarction, congestive cardiac failure in these patients. Not only that, but it has also shown to help macroalbuminuria, weight loss, and there is no hypoglycemia, well tolerated, and there is no increase in pancreatitis in these patients or hospitalizations. This dulaglutide is also known as Trulicity, is dual and triple oral. It can be given a first injectable option in dual and triple oral combination therapies, and it is a longer action. The duration of action is longer. That's the difference in liraglutide and dulaglutide. It's given once weekly dosage. It is ready to use pen. There is low rate of hypoglycemia compared with insulin glargine and a similar rate to liraglutide. It is GLP-1 receptor agonist and shows non-inferior HbA1c reduction to 1.8 milligram. So it is not inferior to dulaglutide. It is a longer acting drug than liraglutide and is available in the name of Trulicity. But it is expensive. So it is again the overview. These are the studies, the award studies which are going on this. And dulaglutide is once weekly. It is a drug to achieve and it is not inferior to once daily liraglutide. Okay, and it demonstrates statistically superior HbA1c reduction. It also resulted in weight loss and associated with lower rate of hypoglycemia versus insulin glargine. There are certain updates in insulin insulin as well. We have newer insulins. So these are the rapid acting ones we talked about. Then this is the intermediate one, and these are the longer acting, the Determer and the Glargine U300, the 300 units one. These are the analogs which are available in market, and these are the pens with which they are available. We can still improve the insulin by making it faster acting, by decreasing its hypoglycemia, increasing the duration, administration, more convenient injections. Also, more work is being going on these different insulins. There is also formulations which are coming up, which are combination of degludec and the rapid insulin. So different combinations are also coming of the liraglutide and delaglutide or deglutide and short-acting insulin. These are also phase 3 clinical trials which are going on, and some of these drugs have also come in the market. Insulin glargine in higher units is also now available. It has shown better effect and it has a 30-hour duration of action. It's available by the name of Tojo. Then we two new basal insulins, glargine and lixacenatide, and degludec and liraglutide are also coming up. Solico and Zultofi, these are the names, and this is all which is going on in diabetes right now. I'm just telling you these, you don't need to worry about it. I'm telling you so that you have an idea. We don't expect you to remember all of these, but you just need to have an idea that there are GLP-1, the incretins, which are GLP-1 and DPP-4, and then there are SGLT2s, which are acting on the kidneys, and then there is insulin. The newer insulins are coming up, and then there are insulins in which the insulins with these liraglutide or GLP analog, the modified GLPs, their combination is also coming in the market. Zultofi is going to be launched next week, so the day you will be listening to this lecture, this will be launched in the market, Pakistan's market. So exciting times in diabetes, and a lot more for you people to learn and read. uh, so liraglutide and empagliflozin reduces cardiovascular risk. GLP-1 agonists and SGLT2 inhibitors are considered first line option after metformin. This is going to happen soon, not soon but in near future. Yes, this is going to will be happening. Many new insulin formulation are there and they are coming up, but the cost is the problem. Their cost is also a problem. These are readily available, the SGLT2s. These are cheap, but these are very expensive and not readily available. Our patients are getting these from Dubai. And the insulins, the new formulation of insulins, are also not readily available. Patient and provider education is crucial to prevent the errors.